Society. I welcome our guests of honor, Dr. Bharti Abhyankar ma'am, Dr. Ajit Patil sir, Dr. Niranjan Shah sir. I also welcome our chairpersons, Dr. Prasad Halkarnikar, Dr. Sheetalnath Neminath Kole sir, Dr. Preeti Deshpande ma'am, and our speaker, Dr. Gauri Saini sir. I welcome I welcome our panelists, Dr. Gauri Shinde ma'am, Dr. Sumant Kulkarni sir, Dr. Nirupma Sakhdev, Dr. Sagar Kataria, Dr. Indraneel Ashok Jadhav, Dr. Pradeep Dorle, Dr. Kiran Sonwalkar, Dr. Milind Peshawikar, Dr. Manjula Peshawikar, Dr. Manisha Laddad, Dr. Monica Kulloli, Dr. Mohini Deshpande, and Dr. Subodhini Jetmalani. I also welcome Dr. Rekha Rajendra Kumar ma'am as the coordinator to this series, and Dr. Monica Umbardan, who is the co-coordinator of this. So with this, I welcome all of you and also all the audience to this 192nd edition of Happy Learning Masterclass. And I would request Rekha ma'am to introduce Dr. Bharti Abhyankar ma'am as our guest of honor.
Yeah, thank you, Dr. Asha Jain, madam, for this kind opportunity from your side. Keith, if you don't mind, I would like to have the CV of Dr. Bharti Abhyankar, madam. Madam is a very senior gynecologist. I would like to have CV of madam, Mr. Keith. Yeah, thank you. Yeah, thank you. Dr. Bharti Abhyankar, madam, is the consultant at Purva Hospital for
Madam,
Yeah.
thank you so much.
Thank you so much. फक्त दोन लाईन मॅडम तुमचं ते रेड लाईन मध्ये काय लिहिले तेवढंच
बस that's all. Thank you.
Elected unopposed as VP of AMOX, that is All Maharashtra Obstetrics Gynec Society 24 to 26, passed international exam and colposcopy as well as cervical pathology with the top scores, conducting Foxy recognized colposcopy training courses in her hospital, and she's published a book in Marathi, Saksham Mein Bhakam Mein.
Thank you so much. Just I want to add one thing, that we, the Kolhapur Society, has got an opportunity to conduct the next colposcopy national conference. Just now, I attended the conference at Raipur. It was conducted by Dr. Asha Jain, a very sincere colposcopist and very good organizer, I should say. And next year, we are going to host the conference at Kolhapur, of course, with the help of my society members and all the Maharashtra society members. So Maharashtra will just show the strength, and we will have a wonderful national conference in 2025. And I extend my best wishes for MC Patel sir, Dr. Asha Jain madam, for their venture in Foxy. Best wishes, ma'am. And thank you for inviting me as a guest of honor. Thank you so much.
Thank you so much, Bharti madam, for your good wishes on us, and wish you a very successful conference on colposcopy. Thank you, madam.
Maybe have Dr. Niranjan sir's CV. Rekha ma'am, you can proceed, please.
Yeah, thank you. I can't see Niranjan sir, but I think I will proceed, and we will take sir's advice and inputs once he joins. Sir has passed MBBS in 1981, MD in 85, and DNB in 86. This is given us a very short CV. I'm sure that he has many more accomplishments. Distinction and first in Shivaji University, Kolhapur. And his fair expertise in vaginal surgeries, and he has lot of tricks in the routine obstetrics gynec practice, infertility, sonography, and laparoscopy. He's an avid fighter for dignity and respect for medical profession. That's a very rare and a very noble quality. Grassroots member of medical organizations. That is Dr. Niranjan Shah. Sir, please unmute yourself. We are eager to hear from you, your words of advice and blessings. Over to Dr. Niranjan, sir. Yeah, he's there. Sir, we can, you can please talk with the video on. We would like to hear from you, sir. Niranjan, sir.
Sir, you can put on video and audio from your...
Audio is on, video is not. Sir, we are welcoming you here and we are eager to hear from you, Niranjan, sir.
Ma'am, he is requesting to unmute and show his video.
He himself should do
He is
it.
requested to unmute him.
Teerth, is there any problem?
Maybe the
for
corona
sir?
people will help.
Hi, unmute and video, please.
He himself has to do.
He has
I'm
to
not
do.
able to do this.
ते तिच्या chat box मध्ये आम्ही
Yeah, he has written please unmute.
yeah, I will write.
He is not able to unmute.
Niranjan sir, would you
When you
please?
go on the name of the Dr. Niranjan sir, there is a 3 dot and just click on the ask to unmute. Niranjan sir.
Where is the 3 dot?
ते म्यूट
We are able
आहे
to
सर
listen.
बघा तिकडे म्यूट म्हणून आहे ना त्याच्यावर ask to unmute. You can say that you please unmute, sir, yourself.
Can you hear me out now?
Yes,
Now you
sir.
are audible.
Okay.
Yes.
Where is the video now? Anyway,
Yeah.
We can see you, sir, now.
you can see? Right.
Yes.
Okay. So, good evening, everybody. The program and the topics taken up are relevant, and I'm very happy that I associate with Dr. Patel, sir, because along with the theoretical knowledge of medical science which we practice, it is nowadays vital to know how can we be medical legally safe. Not only medical legally safe, also safe from other atrocities which are being levied against the medical field. And in future, we will require leadership which can protect most of our and all of our members from any untoward incidents in their practice or in their personal life. So all the best, MC. Thank you very much.
Thank you.
Was I audible?
Yes, sir. Yes, sir. Thank you, Niranjan, sir. We heard your words.
Right.
Thank you so much for joining and giving your inputs to us. Thank you.
Right.
Dr. Asha? Dr. Asha?
Yeah, I'm trying to call Ajit sir, whether he joins or then we can start the session if he doesn't join.
Yeah, we can't see him.
Yeah, I can't see him, but just
Correct.
requesting him to join for a minute. I've tried before.
Yeah.
I think Dr. Rekha.
Yeah. I will start with session 1. Can I have the CVs of the chairpersons, Prasad sir? Thank you. Now we have finished the inaugural ceremony. We will take Dr. Ajit sir's input and advice later once he joins, as well as Dr. MC Patel sir. Now it's my proud privilege to introduce the chairpersons of the first talk. This first chairperson is Dr. Prasad sir, Dr. Prasad Halkanikar. Sir, sorry for that. He's the president of Kolhapur Obstetrics Gynec Society. Aikta na sir?
Yes.
Kolhapur. Doing his private practice in Kolhapur since 1990, that is more than 30 years. Sir's area of interest is infertility and vaginal surgeries. Very, very short CV sir has given. Sir, thank you for joining.
Thank you, madam, for introduction.
Okay, sir. And I would like to have the CV of second chairperson, Mr. Teerth. Yeah, thank you. Dr. Sheetal Nath N. Kole, sir. He's finished obstetric gynec MD in 98, DNB the very next year. Sir is the ex-lecturer in Vanless Hospital, where I did my post-graduation in Miraj. That's a government medical college, Mission Hospital, it's a Vanless Hospital, Miraj, and Karad, practicing as consultant gynecologist at Ichal Karanji since 2002. Sir is the of the same society. Welcome, Dr. Sheetal Nath, sir. We are happy to have you here. Third chairperson, please. Yeah, thank you. Dr. Preeti Deshpande, madam, is MD DNB DGO. She is presently the president of Karad OBG Society. She is the director of Ikopa Hospital and Karad Fertility Research Center, practicing consultant in ART for more than 2 decades in Western Maharashtra. Madam has been awarded many important prestigious awards, including Tulsi Basu Award, Indumati Zaveri Award in AICOG. Also, she is the author of articles in national and international journals and faculty in many of our conferences. Over to all the 3 chairpersons. I request Prasad sir to tell about the topic, Dr. Sheetal Nath Prasad sir to talk about the speaker, Sheetal Nath sir to talk about the topic, and madam to conclude the talk. That is Preeti madam to conclude the talk. Thank you. Over to chairpersons.
Dr. Rekha, one
Yeah.
problem is that we do not have all 3 of them. So Prasad,
Yeah.
sir, requesting you to take over and just handle the session, please.
Yeah.
Okay,
Okay.
madam.
Thank you, sir.
Yes.
Please
CV of-
share.
Thank
Yes.
you.
Please share the speaker's CV.
Dr. Gauri Sai Prasad is a member of our KOGS society, and she is always managing the medical patients in our fraternity, and she is always helpful. Currently, she is carrying out obstetric ICU at the Diamond Super Specialty Hospital, Kolhapur. She has many publications, there, like a study of hepatitis C in pregnancy, then perimyopartum cardiomyopathy, a study of ovarian tumors, and recently she has published a book of protocols in obstetric emergency, and that book is very helpful for day-to-day practice. I invite Gauri Prasad for the talk.
Thank you so much, Sir Prasad sir. It is we are part of Prasad sir's team, so it is very a very big comfort level that we share with our president, and he makes us and pushes us to do things. So thank you so much for the introduction. I'll share my screen now.
Just a second.
Yeah.
Dr. Sai,
Yeah.
MC Patel sir has joined, so I request him to welcome, sir.
Yes.
In your absence, we have actually gone ahead with the initial part and requesting you to give your formal welcome address before we
Yes.
take the program forward.
Yes. So thank you. And before I go with official welcome, sorry for joining late because I was busy with one more webinar and I was conducting very interesting panel. So it gives me immense pleasure to welcome you all on 192nd episode of Happy Learning Masterclass. And today's joining society, Ichal Karanji, Karad, Kolhapur, Miraj, and Satara. So I welcome Dr. Bharti Abhyankar. She has kindly consented to be guest of honor to bless the webinars. Of course, she is always with us in any of our academic activity. Same way, Dr. Ajit Patil and Dr. Niranjan Shah both have also kindly consented to be guest of honor, and they are also with us in any of our academic activity. I also welcome Dr. Gauri. She is going to discuss very important subject, peripartum cardiomyopathy for today's session. And just mentioned by Dr. Prasad also, she has recently come up with protocols in OBGYN. I received book just day before and I quickly went through. It is very useful book, not to the student only, but to the practicing gynecologist also, how to deal with those very situation in given time. It is very important. And congratulations, Dr. Gauri, for the same, and all the best for this type of many more academic extravaganza. I also welcome three chairpersons who are going to chair this session. Dr. Prasad Halkarnikar from Kolhapur, Dr. Sitalnath Kole from Ichalkaranji, and Dr. Preeti Deshpande Madam from Karad. I also welcome all the learned panelists who are going to put questions related to legal issues in labor, and they are Dr. Gauri Sinde Madam from Karad, Dr. Sumant Kulkarni is not going to attend due to some family issue. Dr. Nirupama Sakharao from Kolhapur, Dr. Sagar Kataria from Satara, Dr. Indranil Jadhav from Kolhapur, Dr. Pradeep Dorle from Meeraj, Dr. Kiran Sunwalkar from Satara, Dr. Milind Pisavikar from Kolhapur, Dr. Manjula Pisavikar from Kolhapur, Dr. Manisha Laddad Madam from Karad, Dr. Monica Kulloli from Meeraj, and Dr. Mohini Deshpande from Kolhapur. I also welcome Dr. Asha Jain, who is convener in this series since long, and two coordinator, Dr. Rekha Rajendra Kumar from Bengaluru and Dr. Monica Umardan from Solapur. Monica is also coordinator in this series many times as far as these episodes are concerned, and she is very much helpful to me as far as this type of webinars are concerned. So thank you, Monica, for the same, and welcome Dr. Rekha and Dr. Monica. So
Thank
in
you,
era of COVID, when I started this series with three friends, I never knew that it will be continued for this much period, but it was demand on part of our Foxian friends, and we continued this series to discuss focused topic and to say hello to our Foxian friends on virtual ground. So without wasting much of your time, thanking you all and welcoming you all, the President and Secretary of Joining Societies and all the delegates to this 192nd episode of Happy Learning Masterclass web series. And at the same time, I would like to mention now this Happy Learning family has become 7,000 plus member family as far as this Happy Learning Masterclass web series is concerned. Thank you very much.
Thank you, sir. Thank you for those words. And I would now request, sorry, Dr. Gauri, for the interruption. And if you would please take over.
Yes. Thank you so much, ma'am. Is the screen being seen?
Yes.
Yeah, the topic today is something which we have worked on a lot, peripartum cardiomyopathy. So we are just going to discuss a few diagnostic points because this is a multi-speciality topic which has to be dealt with by obstetricians, anesthetists, and the intensive care specialists who work in the ICU. So this is why it is close to my heart, is it is one of my first publications. We had the highest series of peripartum cardiomyopathy cases, which we had studied at Apple Hospitals, almost about 24 cases. So what and why peripartum cardiomyopathy? So actually the thing when we were studying is that peripartum cardiomyopathy was like a footnote at the end of the cardiac chapter. It used to be a small a small part where there would just be the definition. And right now we see that when there is IVF pregnancies, twin pregnancies, increase in preeclampsias, that we are coming across this peripartum cardiomyopathy much more frequently. So there are other causes of cardiomyopathy also, but we will be sticking to peripartum cardiomyopathy. So definitions. So what is the definition of peripartum cardiomyopathy? The latest 2010 definition of the European Society Cardiology Working Group is heart failure at the end of pregnancy or the months following delivery. So heart failure at the end of pregnancy or the months following delivery. The initial definition, which was what we have studied when we were doing our PG, is in the last trimester or almost up to 6 weeks following delivery. But now it is included even in after 28 weeks of pregnancy also, when there is a isolated left ventricular heart failure towards the end of pregnancy or the months following pregnancy, it is one of the criteria for saying it as peripartum cardiomyopathy. There should be no other identifiable cause of heart failure like preeclampsia or any other cardiac condition or any other pre-diagnosed cardiac condition. A left ventricular systolic ejection fraction less than 45% without. Can you see the slide?
Ma'am, we can see the slide.
Yeah. So the salient features of some of the peripartum cardiomyopathy is very much similar to third trimester symptoms. So third trimester symptoms, just one second.
Any problem, ma'am?
No, I'm not, one second. Yeah, got it. So the third trimester symptoms are something like fatigue, dyspnea. She comes to you with a pedal edema. And usually we say that, hey, this is all very common in third trimester. Always keep your mind open for risk factors of peripartum cardiomyopathy. So whenever a person with risk factors for cardiomyopathy comes to you with some common symptoms, always think that does she require a physician reference. Epidemiology, it is quite high in the USA. Haiti, which is a small country in the American continent, is having the highest incidence of peripartum cardiomyopathy, 1 in 300, and Nigeria, in certain parts of Nigeria, it is almost like 1 in 100. So in India, there is no published incidence. What is the etiology? This very theoretical part. So angiogenic imbalance, vascular endothelial growth factor inhibitors, role of prolactin. So this will come to later because prolactin, the role of prolactin in causing this peripartum cardiomyopathy is being used in the treatment part where we give bromocriptine. Inflammatory cytokines against the myocardium, probably a myocarditis, inflammatory myocarditis, abnormal immune response during the end of pregnancy, and in some families, it runs as a familial disease. So what are the risk factors and associations? More than 30 years more common. South Asians have a moderate risk and we fall as South Asians. And multiple fetuses means in twin pregnancies. Preeclampsia, eclampsia, postpartum hypertension, concomitant use of oral tocolysis, and cocaine abuse. So this is a very crowded slide. This is signs and symptoms. So signs and symptoms are the same which you find for left ventricular failure. So cardiac signs and symptoms will be tachycardias, arrhythmias because of atrial fibrillation, palpitations, normal or raised blood pressure, low BP in late disease when the cardiac output has decreased. Of course, the apex beat and all that will not be much able to find out in near-term pregnancies. But in postpartum state, we can see that. Gallop rhythm, third heart sound showing typical heart failure signs, elevated JVP, hemoptysis and increased pulmonary capillary wedge pressures, new murmurs consistent with regurgitated murmurs, and sudden cardiac arrest in the late cases. So the other thing about peripartum cardiomyopathy in an acutely dilated left ventricle is occurrence of peripheral vascular emboli. Abdominal hepatosplenomegaly, abdominal discomfort secondary to CVC or chronic venous congestion. Now the diagnostic tests available. So ECG, sinus tachycardia, AF, it may show. BNP is natriuretic peptide that is increased in peripartum cardiomyopathy. I'll come back to that later. A doubtful role for chest X-ray in the antenatal period, but can be done if totally indicated. Echo is the most common diagnostic test that we require for diagnosing peripartum cardiomyopathy. Cardiac MRI, cardiac catheterization, and endomyocardial biopsy. So these last three are just to do a differential diagnosis when we are in doubt. So a summary of the investigations, I would like you to look at the echocardiography. So the echocardiography, left ventricular systolic and diastolic function with or without left ventricular dilatation. So before 2010, there was a criteria for left ventricular dilatation measurement also. But now we are going only with the ejection fraction, which is less than 45%. So left ventricular thrombosis, when there is a severe left ventricular involvement, there may be a concomitant right ventricular involvement. Exclusion of pre-existing diseases like coronary artery disease, and assessment of lung congestion. So the main diagnostic features can be done with an echocardiograph itself. So doing a magnetic resonance imaging or a CMR and genetic testing is all theoretical basis only. Now the diagnostic algorithm. So in the history, heart failure symptoms onset in last few months of pregnancy or first few months after delivery, and no previous history of cardiac disease. If these are the symptoms, then it will go into the clinical examination where there is signs of a systolic heart failure in a normotensive patient. Here, you have systolic heart failure in a hypertensive patient, then we must consider hypertensive heart failure rather than peripartum cardiomyopathy. Now, how will you differentiate these two? By doing the echo. So, echo will tell you that the EF has fallen. In hypertensive patient, the EF will be quite normal. So, transthoracic echocardiogram, LVEF less than 45%, then you do all this. So, X-ray, ECG, natriuretic peptide. Left ventricular fraction, if it is more than 45%, then you need to consider alternative diagnosis. So what are the differential diagnoses of cardiomyopathy? Valvular heart, congenital heart disease, hypertensive disorders, and acute coronary syndromes are the most common things that we come across. Now, myocarditis, pulmonary embolism per se occurring in a low risk patient is quite rare. So the what we need to consider is valvular heart disease, congenital heart disease, which has not been previously diagnosed. Now, if you look at this, just see this. This is the four chamber view of the heart, LA-LV, RA-RV. So you have a dilated left ventricular. So the global dilatation of the heart will give you a different, also be peripartum cardiomyopathy if global dilatation may also be peripartum cardiomyopathy only in the late stages. That time only the LV will not be dilated. That time the whole heart will be in will be dilated. So in the LV, if you notice here, the LV is very much more dilated. The walls are much more thinner as compared to the rest of the heart. Now, echo features, findings in women with PPCM are considered consistent with findings in the heart failure. So decreased EF, global dilatation, thinned out cardiac walls, increased LV mass, and diffuse LV hypokinesia. So how do you manage? So management is multi-pronged. So as soon as you have a suspicion that this patient may be having peripartum cardiomyopathy, you have a patient with twins and she comes to you somewhere near term around saying that suddenly she is having breathlessness, she's sitting, she's not very comfortable. And then you feel that no, I cannot be seeing her in my OPD. I need to refer her to a physician. So management is a multi-pronged management. So management is 4
म्हणून
specific
जायला जाणार आहे
things.
मी. आमच्या सासऱ्यांचं ते करतात ना. जाऊन येणार आहे. उद्या 10 मध्ये
Treat
पेशंट
the failure, see if any, and specialized treatment. So treating failure is very simple. So treating failure, we have to decrease the afterload. So decreasing the afterload means decreasing the pressure against which the heart has to pump, because already the ejection fraction is very less with diuretics.
Dr. Gauri?
Treating the arrhythmia. So the most common arrhythmia in peripartum, treating the thrombus, because the LV is dilated and it is hypokinetic. There is stasis of the blood and there is thrombus formation in the left ventricle, which can be pushed out into the circulation anytime. So anticoagulation is a must when there is severe LV dilatation. Specialized treatment whenever ventilation is required, devices like a left ventricular assist device, immunomodulators, and the new thing called bromocriptine. So if the response is good to the conventional heart failure therapy, continue the heart failure therapy. If there is poor response, add further inotropes and IABP. IABP will help increase the pumping out of the left ventricle. Response is again poor, continue IABP and continue vasopressors. If the response is poor and she is going into multi-organ dysfunction, we have the new thing that is extracorporeal membrane oxygenation. So that we have done quite a few in Diamond Hospital, but not in a peripartum cardiomyopathy patient. So in such dire situations, ECMO can be tried out. If there is a good response, again, we go back to weaning. If the response is poor, then we have to go to case-by-case approach. Now, this left ventricular assist device or Impala, now these are all beyond the scope of this presentation. So these are all devices which help in increasing the left ventricular ejection fraction. Bridge to transplant and bridge to recovery. So these are temporary measures wherein when you are considering a cardiac transplant or when you're waiting for recovery. Now, how to use bromocriptine? If the LVEF is more than 25%, means a hemodynamically stable patient, then we start off on bromocriptine 2.5 milligrams once daily for 7 days. If there is less than 25% EF, means it is quite a poor or a very mildly contracting heart, and or right ventricular dysfunction or cardiogenic shock, increase the dose of bromocriptine to 2.5 BD for 14 days, followed by tapering of the bromocriptine. Now, ICU treatment, cardiogenic shock with invasive ventilation, then start with bromocriptine 2.5 milligrams twice daily. It is an assist in the ICU treatment. So in all this, you see, we have to continue with prophylactic anticoagulation. So delivery, a multidisciplinary team is involved in management. So joint decision on delivery timing. If you are unlucky enough to come across a peripartum cardiomyopathy in the antenatal period. So labor is allowed in hemodynamically stable patients. Augment, don't prolong labor. PPH management. Again, we are stuck over here because we cannot use drugs which cause peripheral vasoconstriction and increases the preload. So there should be a very judicious use of oxytocics, and there is a doubtful use of carbitocin here. Caesarean section is only for unstable patients and obstetric indications. Anesthesia, general anesthesia is preferred. Labor anesthesia is to be individualized because labor anesthesia usually results in a little bit of more prolongation. So breastfeeding, it is not contraindicated in stable patients. Contraception, combined pills are totally contraindicated because estrogen increases the risk of thrombus. So you have progesterone only pills, IUCDs, and sterilization. So this is a slide I found today. I have just lifted the whole slide. This is peripartum cardiomyopathy prognosis. So what is the prognosis once you diagnose a peripartum cardiomyopathy or once she is on the road to recovery? So continued recovery of the LV function takes almost 6 to 12 months, and in some unfortunate cases, it may take a lifetime. So usually it returns to normal heart size within 6 months. 30 to 50% will recover the baseline LV function within 6 months. So prognosis is positively related to recovery of the baseline LV function. Failure of LV size to return to normal is associated with maternal mortality and morbidity. So 95% survival in 5 years, mortality varies only when there is no recovery to baseline levels. Recurrence risk in subsequent pregnancies may be as high as 30 to 50% in some studies. So subsequent pregnancies, women with previous PPCM, left ventricular function recovery now at the end of 1 month, at the end of 2 months, and at the end of 6 months, we need to do her totally is almost 27% with no mortality. High risk of left ventricular dysfunction when there is less than 50% EF. So then you have to subsequent pregnancy should be totally discouraged because the mortality rate itself goes up to 25%, means 1 out of 4 women may not make it through the pregnancy. So at the end of 6 months, if her left ventricular ejection fraction is less than 50%, totally discourage pregnancy and write it in your notes. So what are the practice points we take home? Keep your diagnostic mind open. Involve consultants for joint management. Counseling is very, very important because they will say, "Te kuthon cardiac disease aale, she was never a cardiac patient." Familiarize yourself with echo findings. Now here I would like to tell one of the things that we are doing in our hospital is we are all very, very familiar with ultrasounds. So it doesn't take much to take our probe and put it at the chest and to see how the left ventricle is contracting. So you don't need a specialized probe. You're not going to do a detailed echo. You can look at the left ventricle and see whether the left ventricle is contracting properly or not. Actually, this you can do with every patient. Be aware of the cardiac drugs being used, especially in the antenatal period. Have a tie-up with a good obstetric ICU setup. Try to follow up post-delivery also. Write clear instructions about follow-up and risks of the next pregnancy. Thank you for allowing me to share our experiences on peripartum cardiomyopathy. And I would take questions if there are any.
Over to you, Prasad sir.
Yes. Thank you, Gauru madam. Actually, while practicing in obstetrics at private places, it is important to suspect the cardiomyopathy and diagnose it. And after that, it is all the role of people like you at ICU level. And after the management of everything, it is contraception and prognosis and advising about the next pregnancy.
Yes.
That is the main role that we have to carry out in these kind of cases.
Yes,
Thank you,
very
madam.
much,
Thank you
very
for your presentation.
Dr. Kole is also here, sir. Would you like to say something?
Yeah, thank you, Gauri madam, for this wonderful insight into peripartum cardiomyopathy. It's one of the dreaded complications. Actually, we rarely encounter, but once we encounter it, actually there should be a high index of suspicion, and we should be able to diagnose it as early as possible so that we can refer the patient to higher center or take him to loop cardiologist and manage the case. And subsequent pregnancies, as madam has already said, avoiding of further pregnancies. Patients should be discouraged from having further pregnancies. So stock will help us a long way in managing the cases of peripartum cardiomyopathy and diagnosing the cases.
Yes.
Thank you.
Yeah. Thank you.
Thank you. Thank you so much. So we are at the end of our lecture. Patel sir, do we
Yes, we
proceed
can.
with the panel now?
Oh, yes.
Okay. Okay. So just a second. So welcome to this panel on, it's a reverse panel on legal issues in labor. Dr. MC Patel sir is the expert and I'm the coordinator for this. I would like to introduce our respected moderator, expert, Dr. MC Patel sir. Everybody knows him, but still it is a pleasure to introduce him. Sir is a consultant obstetrician, gynecologist, and medico-legal counselor, VP Foxy 2018, Organizing Secretary AICOG 2017, Chairperson Ethics and Medico-Legal Committee Foxy 2011 to 13, Honorary Secretary SOGO, Organizing Chairperson MMCon, Honorary Member National Inspection and Monitoring Committee PCPNDT, Honorary Member of the State Supervisory Board PNDT Committee. He was the President of Ahmedabad Society, Honorary Member National Managing Body Red Cross Society. He was VP Foxy also. And now the most important thing is he's done a lot of conferences, but he became the chairperson of Ethics Medico Legal Committee Foxy in 2011. And for the past 14 years, he has been an easily, always accessible medico legal expert for every gynecologist in trouble all over India, all the time, 24/7, 365 days a year. Also, he goes to the Northeast and he has been giving consistent service to the underprivileged women there at least a week every year, and that too for 21 years. So as you can see, consistency, dependability, approachability, these all factors are there. And sir, I've been introduced, and sir is a candidate now for Foxy President election year 2024. Here is a short appeal from sir. So
शुभं करोतु कल्याणं आरोग्यं सुखसम्पदम्.
Respected seniors and dear colleagues, serving Foxy for years together, on this auspicious day, with folded hands and down head, I seek your guidance, blessings, and support to endorse my candidature for the post of Foxy President year 2026 election year 2024, consistently working for Foxy and trying to visit even a smaller societies and to assist our common Foxian friends in any given situation. I have tried to serve Foxy. I assure to serve Foxy in the same way with the same zeal and enthusiasm. पथ का अंतिम लक्ष्य नहीं, सिंहासन चढ़ते जाना, लिए सभी को साथ, आगे है बढ़ते जाना.
Thank you, sir. So would you like to say something before we proceed?
So, it is my humble appeal to endorse my candidature for post of President Foxy this year in election year 2024, considering my seniority, sincerity, dedication, and easily availability to any Foxian friends in any odd given medical legal crisis. Please consider all these and please endorse my candidature. Please support, please vote, and in this month of May, communication is received by respective society president secretary for nomination. So first you will have to nominate me for the post, President Foxy, and in month of August 1 to 10 there will be election. So please vote at that time. Thank you very much.
Thank you, sir. So I would like to introduce my panelists as they come along one by one. And meanwhile, I would like to introduce the session by my usual most irritating question. Is this even worth discussing? Patel, sir? Is this topic worth discussing? Sir has probably had a call immediately, so I would like to meanwhile request all of you from your respective societies, please nominate me for chairperson, Food, Drug and Medico Surgical Committee. Yes, sir, over to you.
Yes.
Is this worth discussing?
Yes. So as far as medical legal consequences are concerned, if we go with statistic of USA, almost 78% gynecologists are sued at least once in their lifetime, and almost 37% gynecologists are sued more than 3 times in their lifetime. And if we go with statistic from India, then as on today, total number of medical legal consequences, gynecologists rank first, and it is 29% or so, followed by 22% orthopedic, and then surgeon. So we are in driving seat as far as medical legal consequences are concerned, and that is why we have to understand this subject and how to manage all our cases not to end up into litigation. And if at all we ended, then how to get rid of this is the main situation. And as far as some complications which goes with residual effect, either with fetus or with mother, they all are potential cases as far as litigation is concerned. And any complication, any untoward effects or side effects rather, they are not mentally prepared to accept it, because they consider normal delivery or labor as a physiological phenomena rather than pathological phenomena. And as we deal with two life, naturally a fetus and mother, so it becomes very potential as far as this part is concerned. And that is why we have to be careful. And as far as legal aspect is concerned, we should be more vigilant that way also.
Thank you, sir. Thank you so much for laying that foundation. And now I would request and invite Dr. Gauri Shinde, ma'am. So she is AP at KMCH Karad, and her hobbies are reading, cooking, gardening, and watching classic movies. So over to you, Dr. Gauri, ma'am. I would have loved to have some photographs of your garden. Okay,
Yes, madam, surely.
over to you, ma'am.
So my question to you, sir. So why there are more of a medical legal litigations, particularly related to pregnancy and labor? And I would like to explain these by giving some uh, real life events.
Yes, yes. So litigations are common related to pregnancy and labor. Very important thing, because usually they are young patients. And in any young patient, any morbidity or mortality is not at all acceptable to the family members also. So this is one reason. Usually they are book patient. Of course, there could be some unbooked patient also. They straightway come in an emergency, but usually they are book patient. Usually they come on foot. Of course, in few of the condition they are brought in an ambulance or so. But it is very rare. Otherwise they come on foot. So patients and relatives are not mentally prepared to face any complication related to this pregnancy part is concerned. And there are so many cases decided in different courts of law as far as this type of cases are concerned. So this is very important part. As far as some areas for litigation are concerned, and it is common allegation in day-to-day practice as far as medical legal consequences are concerned, delayed in diagnosis or investigation or treatment. If there is a case of PPH, and if we have delayed to diagnose and delayed to deal with situation, it could be allegation in medical legal problems. Wrong diagnosis, no consent, infrastructure issues, staff problem, unnecessary investigation. It has come nowadays a common allegation that this investigation were not required, and the doctor went with this. So this is also one more allegation as far as indication, I mean unnecessary investigations are concerned. Emergency service is not rendered properly. This is also one more area. And delayed transfer. If patient is to be transferred to higher center for further care, and if it is delayed in transfer, this also becomes one more area as far as litigation is concerned. And major congenital anomaly in case of our obstetric practice, many times if we miss, even in spite of sonography, any anomaly and baby delivers with anomaly, then this becomes also one more area for litigation. Morbidity, maternal or fetal, and in few of the cases mortality, maternal or fetal, these are some areas for litigation. And many a time in our other practice, failure of procedure or some complication related to that. Say, for example, if we have induced labor and if we fail, and at the time of counseling, we have counsel that we are going to induce this labor and let us see how the progress. And if at all we have to switch over to cesarean section, then they are not mentally prepared. So failure of procedure also could be one of the uh, area as far as litigation is concerned. Trauma or injury, birth related injury or birth injury, either maternal or fetal. Say for example, perineal laceration or hematoma or urethral or paraurethral injury or BVF, RVF. Of course, they are rare, but if at all they occurs, then it becomes a very potential area as far as litigation is concerned. Injury to fetus, say for example during cesarean section, if it is cut mark on body of fetus at the time of opening uterus, could be one more area as far as litigation is concerned. Fracture clavicle, fracture long bone, and or palsy, CP. These are some areas as far as fetal part is concerned. And just I mentioned prior also some anomaly related to fetus. So these are some areas as far as litigation related to labor or cesarean section is concerned.
Sir, regarding this, in such situation, if we are predicting such situations, can we take a prior high risk consent regarding
Yes,
these situations?
yes.
And in which it should be in a written form, or it should be a like a video
No, no.
of the consent.
Both are accepted in written form also and in video also. But as far as video recording is concerned, I usually say it is double-edged sword. Because if you miss very important
Excuse
points,
me, sir. Sir,
yes.
these are questions that are coming later. You cannot
Okay,
repeat them right now, please.
Okay. So she was telling about consent. So we are going to take in another area, no issue. But we were discussing common allegation as far as litigation part is concerned.
Yes, sir, but you cannot detail them, na, because they are coming.
No issue. So many a time improper diagnosis of fetal distress could be one of the allegation. Improper monitoring or process of labor leading to complicated labor, or improper interpretation of CTGs, improper application of instrument if we are going to go for instrumental delivery, and if some injury occurs, then this could be one more allegation. And improper conduction of labor causing perineal tear or any other tear, so birth injury. And this is very a tricky situation for us, because on one hand, media crying loud about increasing rate of cesarean section, and on other hand, many litigations have filed not doing cesarean section in time. So our situation is very difficult. So whatever we do, we should be in a position to justify in court of law.
Thank you,
Thank you, sir.
So, sir, next we proceed
Yes.
to Dr. Sumant Kulkarni, sir. He loves traveling, but there's an emergency in his home. He's the president of Meerut Society. So, I request anybody, please, would you take
Anybody
this
from Meerut can take.
anybody here?
Suman had a phone call to me. He is unable due to some emergency in family. And now anybody from Miraj can take this question, no issue.
Anybody present here can take the question.
Anybody can take, no issue.
Dr. Gauri, would you like to continue with this?
Questions are not visible, madam.
Ma'am, it's there on the screen.
Make it full screen.
Make it full screen, it's there on the screen.
Okay.
Sagar sir, would you take it? You
Yeah.
are there on a computer, I
Yes,
think.
yeah. So, see, this is a case of baby Ramya versus Dr. Aruna Reddy. In this case, there was a forceps delivery and baby 4.5 kg baby was delivered vaginally by applying forceps. And later on, the baby developed brachial palsy, and the case was filed against the doctor. On part of doctor, he defended that this was a complicated case. Patient refused consent for cesarean, and baby was getting asphyxiated. There was fetal bradycardia. But the court held that the baby patient was admitted at 6 a.m. and delivery started at 6 a.m. and delivery started at 4 p.m. There were no investigations or sonography, and the evidence that consent was refused was not there. So where the doctor was given punishment of 1.75 lakhs, and the patient was awarded with this 1.75 lakh compensation. So where the doctor went wrong in this case, sir?
So it is very good case when it was decided, because baby was 4.5 kg and normal vaginal delivery was planned. So in this type of situation, all probable complication we should explain to the patient before we go for planning of vaginal delivery with this big baby. So this was one more area. One more area, he has mentioned that when he asked for consent for cesarean section, they refuse. So here comes role of negative consent. If they refuse, then we should have a negative consent also, that it was explained to us, but we are not ready to give consent. But many a time what happens, patients are not ready to give negative consent also. So in this situation, you mention everything in case paper, and you can have a consent from co-patient or any visitor of hospital, that before us it was explained to the patient and patient party, but they were not ready to give consent. So if we have taken like this, then it becomes a good defense in our favor, because when patient or patient party do not comply with our advice, then it becomes non-compliance on part of patient, and it is a contributory negligence on part of patient, and it becomes good defense in our favor. So this is one more area. One more allegation was that she was admitted at 6 a.m. and delivery started 4 p.m. and no investigation or sonography or evidence of consent was refused. So as far as any investigation is required, if progress of labor is very normal, usually we do not subject any patient for any investigation. If at all it deviates from our expectation, then only we subject for some. So in this type of case, how you have documented and how you represent that documented thing in court of law is very much important. And in this case, when this earth palsy was diagnosed and this allegation came that due to that forceps there was injury to the baby and she developed brachial palsy. So in this situation, if at all we are going to go for instrumental delivery, then also we have to counsel patient well. And as far as consent is concerned, it is available on Foxy website with Foxy uniform consent. So we have prepared consent for normal labor. We have mentioned everything as far as instrumental delivery is concerned, and for cesarean section we have separate consent. And now it is available in Marathi also. So whosoever is interested can contact me. I can send you a soft copy of Marathi as well as English version. Yes, next.
Thank you, sir. So next we have Dr. Nirupama Sakhadev, who is the past president of Kolhapur Society. She likes reading fiction and non-academic scientific material. So over to you, Nirupama ma'am.
Yes.
Sir, requesting someone from Kolhapur, would you please take this? Milind, sir, would you take this, please?
So this is Nina Gupta versus Deep Nursing Home, 1996, CPC1. It was a forceps delivery, it seems, and then the patient had uterovesical fistula. The defense on the part of the doctor occurred during the process. Inference held by the court was liable. So where things went wrong is the question.
So again, in this case, when she was subjected for instrumental delivery, that is forceps delivery, so proper counseling is very much required. And usually in forceps delivery, uterovesical fistula usually doesn't happen if it is properly applied. But if it is obstructed labor, if a head is stuck up for some longer period, and if there is a pressure necrosis, and after some days, when this pressure necrotic part is sloughed out and fistula develops. So just I mentioned prior also, as far as this type of cases are concerned, we have to counsel patient well. If it is a obstructed labor, then these are some probable complications. Let us see that they will not happen. But if at all they happen, then it is likely that they may happen. So if we have counsel and if they are mentally prepared to face this type of situation, then it could be good defense in our favor.
But again, sir, the question
Yes.
here is, are these complications known or not known? And then
Known.
why should the court
Known.
hold it
So,
against the doctor?
Yes. When these are known complication, how court will decide? Because court is not expert in medical science. So they go with some areas, say for example, standard textbook. So what is written in standard textbook as far as instrumental delivery is concerned, which are the probable complication, how instrument is applied, how it goes, how it can be failed. So what goes with this? One more area, practice prevailing in nearby medical college. So how in nearby medical college they deal with patient in this type of situation. One more area, standard treatment protocol in some journals or protocols by RCOG or ICOG or FOXY. So court consider all this, or peer group. So in group of gynecologists with the same experience in that very area, how they practice, this also taken into consideration, and references with expert. In this type of situation, whenever you are facing, then you can request court to invite expert witness in your favor. Same way patient can also ask to invite expert witness in her favor also. But if court is agreed to allow to invite expert witness in our favor, then all this paper of treatment given will be given to that very expert, and expert will opine that in that very given situation, whatever treatment done by doctor or gynecologist was as per standard medical norms, then you could be out of problem.
So as much importance has to be given to counseling, consent, and also presenting the case in a proper way.
Yes, naturally. Proper documentation is not sufficient, but proper presentation of that very document is equally important.
Thank you, sir.
Yes.
Thank you, sir. Now we have Dr. Sagar Kataria, sir, past president of Satara Society, and he is an avid marathon runner.
Very good.
So, and even now, every week, at least 3 days, he's running. Other days, he's playing badminton. So, over to you, sir.
Thank you
Sagar,
for the kind words, ma'am. Sir, we are right from the beginning, we are discussing the same thing about birth injuries and litigations. Nowadays, there is a lot of pressure from government as well as from common public to reduce the cesarean section rate. And on the other hand, there are a lot of litigations about forceps and vacuum deliveries and leading to birth injuries both to the mother and the fetus. So I'd like to ask which injuries are more likely to cause litigations, whether to go for forceps or whether to always go for section.
Whatever we do in a law, there is very common dictum. Whatever we do, we should be in a position to justify in court of law why we did it and was it our decision scientific. But as far as this maternal and fetal injury part is concerned, obstetric anal sphincter injury is one more area. We may call it third degree perineal tear or complete perineal tear. So in this type of situation, when patient ends up with any residual effect, then it becomes area for litigation. Then I just mentioned prior also vulval or vaginal or perineal hematoma or lacerations, paraurethral or urethral injury, VVF, RVF, cervical trauma, rupture uterus, whether it is repairable or uterus is to be removed. These are some areas as far as litigation is concerned. And as far as fetal part is concerned, fetal asphyxia, or we may call it birth asphyxia also, Kiphel hematoma. Then fracture, I mentioned prior also, fracture of skulls, fracture long bone, fracture clavicles, earth palsy, injury during breech delivery, because this is also a very common part. And sharp cut injury on body of fetus during cesarean section, I mentioned prior also, of course. And perinatal death. These are the some areas as far as litigation part is concerned. And just I mentioned prior, and I repeat, if fetal injuries are leading to permanent liability, then it becomes an area for litigation.
Sir, nowadays there is teachings in medical colleges that you should wait for 2 hours or even more for second stage of labor. As long as the baby's head is in the on the perineum, it will compress all the surrounding vessels and will it the more the prolonged labor, more are the chances of third and fourth degree tear or even fistula. So, what is the way out?
So, just I mentioned prior, whatever you do, you should be in a position to justify your action. So, if you can wait and if you have waited, then also you have to justify why you waited. And if you are going to go for section, then also you have to justify why you went with cesarean section. If at all there is guideline on part of government, fine, we have to obey, but not at the cost of injury to the patient or some untoward or unexpected outcome on part of patient.
Yes, thank you, sir.
Thank you, sir. Now we have Dr. Indraneel Jadhav, sir. He's the secretary of Kolhapur Obstetric Gynec Society and he's a FOGSI recognized colposcopist. So, welcome, sir. Dr. Indraneel Jadhav, sir. Please unmute yourself.
Yeah, today we'll be discussing like what is negligence and what are types of negligence, what qualifies to be a negligence according to court of law, and how we can prevent that a negligence has actually occurred. And what are the types of negligence?
In our medical curriculum during forensic medicine, we were taught two words, act of omission and act of commission. So what is act of omission? Means not to do something which a reasonable prudent doctor always do. Say for example, if patient comes to you having penicillin injection. So any prudent doctor would go for negative test dose, and if it is negative, then only he will go with full dose. If without doing negative dose test dose, full dose is given and something goes wrong, then it becomes a act of omission. Same way, act of commission means doing something which prudent doctor would not do in the same situation in same given time. Say for example, if you have planned surgery and planned surgery is under general anesthesia, and on interrogation when patient is admitted, patient gives history that she has come with full stomach. So no prudent doctor will go for general anesthesia or surgery with full stomach. And if one goes, then naturally it will be an act of commission. So this is negligence. But as far as to define negligence, there are four ingredients of negligence. One is legal duty. What is legal duty? So as soon as any patient comes to your clinic, and if you accept to treat her, your legal duty starts from that point of time, and it becomes a contract or implied contract between patient and yourself. You are offering your expert services, and patient pays for that, or patient promises to pay for that. So that is legal duty. One more area, more ingredients, that is breach of legal duty. For any reason, if you have not treated that patient as per standard norms expected in medical science, then it becomes a breach of legal duty. That is negligence, carelessness or deficiency in services as far as your legal duty is concerned. One more area, damage suffered by patient. So, legal duty, breach of that legal duty, and damage suffered by patient. And fourth ingredient is very important, that is your action. So, action of doctor should be direct and proximate to cause that damage to the patient. So, if it is proved in court of law that action of doctor was direct and proximate to lead to damage to the patient, then only negligence can be proved. And as far as types of negligence is concerned, so usually we go with two negligence: civil negligence, that is tort, and criminal negligence. So as far as civil negligence is concerned, in that whichever damage suffered by patient is taken into consideration, for that compensation is allowed. As far as criminal negligence is concerned, and in that very negligence, it should be gross negligence and high standard of recklessness. So if negligence is gross, then only it will be considered as a criminal negligence. Otherwise, it can be considered as a civil negligence.
Sir, like if we go for some small example, like during a cesarean section, there is a bladder injury. Now we are not in capacity to call urologist to repair it. Suppose the obstetrician repairs it, and now she has future problems regarding that. And if the case stands, so under reasonable circumstances, we should have called urologist to repair.
Yes.
But per se, that was not feasible in the conditions which were pertaining to the surgery. So what it would be considered as negligence in court of law, or it would be considered as no, the act was reasonable for the situation?
So
Because many
here there
times we
are,
face these situations.
yes, here there are two situations. Court always consider where you are practicing, whether urologist is available nearby or not. If urologist is not available nearby, and if you have encountered with bladder injury or so, you can very well repair that very injury. But here, very important part is post-operative counseling is equally important. That with this was happened, I have repaired this, and these are some probable complication if at all it may occur in future, and these are some instruction you have to strictly follow. And if you have given all, say for example, naturally in this type of situation, we will go with catheterization for longer period. So as far as catheter care is concerned, we have to mention everything in discharge card also and explain to the patient. If patient doesn't follow our instruction, and if some complications happens, then it becomes a contributed negligence on part of patient, and it becomes good defense in our favor. There is non-compliance on part of patient.
But
So
if at all
it is very important.
urologist is available, urologist is
I
available, but not
coming to
in,
that. I am coming to that. If urologist is available nearby, then it is always better to involve. If it is an
he is not in
emergency,
capacity to serve our case, then how it should be taken further?
pardon?
If he is not in capacity to help us, and we lastly decide to work on ourselves, then how
Then just I
that should be
mentioned, you
proved?
can very well proceed accordingly, but you will have to prove that you tried to contact urologist was not available, or he was not in a position to help, and there was no way out to deal with situation accordingly. So if you can prove this, then you are out of problem. Because in any case in court of law, ultimate result or complication is not taken into consideration, but your efforts to save life of patient or to deal with situation in that very time accordingly, as any prudent gynecologist would have acted or treated, it is taken into consideration.
No, like if types of negligence, what you have told, sir, like a simple case, like we are doing a DNC and we hold a DNC or only biopsy, people biopsy without anesthesia. We held the cervix with Alice forceps or valsalem, and due to that, the patient goes into vasovagal shock and may be amounting to mortality or maternal mortality. Then in this situation, how do we define a thin line between civil and criminal negligence?
Yes.
And what actually amounts to criminal negligence, which is more dangerous? That should be known so that we can avoid it.
So it is very clear, as far as this type of situation are concerned, so we go with cervical dilatation under local anesthesia or biopsy or etc. So in this situation, very important question we have to face in court of law. Say for example, vasovagal shock happened. So very important questions comes, was it preventable? And usually you cannot say no. So what measures did you take to prevent it? Say for example, injection atropine. Usually we go with injection atropine for any surgical intervention like this. If we have not given atropine, and if it is proved in court of law that it was vasovagal shock, then it could be troublesome for us to face. But so that is one question. Second question. So what did you do to prevent it? And if at all you take all the measures and you couldn't prevent it, then did you diagnose that complication well in time? And one more question, did you manage that complication way in which any prudent gynecologist or doctor would have managed? Say for example, if it is a vasovagal shock, in spite of our atropine given or atropine not given, and vasovagal shock happened, then what is expected from any prudent doctor to deal with that very situation in that very given time? So we have to prove in court of law that we manage that very patient in that given situation as per standard medical norms. So if we can prove in court of law, then we could be out of problem.
Okay, thank you, sir.
Yes, next.
Next, we have Dr. Pradeep Dorle, sir. He's the secretary of Miraj Society. He would not be able to join, sir, as you know.
Okay,
So,
no issue.
requesting anybody present here, if you would please take the question. Anybody present here? Yes, Dr. Gauri.
So, what is the importance of consent, and is the consent necessary in the normal labor? What is the importance of record keeping, and what is the importance of discharge card regarding obstetric cases?
Yes. So important of consent. Naturally, when patient is major, when patient is mentally sound, patient will give consent for any treatment, whether intervention, whether normal delivery, whether instrumental, whether cesarean section, or any surgery even. So consent is very much required, because without consent, whatever you do, it is not pardoned in court of law unless it is an emergency. If it is an emergency, whatever you do to save life of patient, it is always considered and is pardoned in court of law. Otherwise, without consent, it is difficult. I would like to mention only one thing.
है ना,
It
तो
was
वो
case of
ऐसे ही
primary
हुआ होगा।
infertility
यदि
and
डायरिया
patient
होता
was
है या
subjected
कुछ
for
होता है तो बताना।
diagnostic
बस
laparoscopy.
पुदीना या
And
हाजमा
consent for the same was taken. But when the gynecologist put laparoscope inside, he showed that it is a case of PCOD and there were big ovary bilateral. So he went with ovarian drilling. For the same, consent was not taken. And case was filed, case was decided against her. So here comes importance of consent. So without consent, any surgical intervention, one should not go. So it is very much necessary. Second question, in case of normal labor. Yes, in India, it is not routine practice to take consent in normal labor. But we never know. Labor may end up into, just I mentioned prior also, complete perineal tear. And you have to repair under anesthesia. Then also you will have to go for consent. So at the time of this going for normal labor, we have to go for consent with all this explanation. And just I mentioned on Foxy website, it is available. We have prepared consent for normal labor. And in that very consent, we have mentioned everything, that which are the probable complications during normal vaginal delivery, which are the probable complications in instrumental delivery also. And if at all we have to switch over to cesarean section, then separate consent for cesarean section also we have prepared, and which is available on Foxy website. As far as record is concerned, so naturally records are always at your rescue, because it is very common dictum, good record is good defense, poor record is poor defense, and no record is no defense. If you say, for example, in any emergency, if you have given oxygen to the patient But if you have not mentioned in case paper, then it is as good as you have not given oxygen. So whatever you do, it should be well documented, and it should be presented in court of law whenever required. As far as importance of discharge card is concerned, it is a very good question, I would say, because at the time of discharge, we issue discharge card. We go with all the details of treatment given to the patient and all the personal information of patient. But here in discharge card, instruction to be given is very much important. Say, for example, diet to be taken, medicine to be taken, exercise, follow-up, and references. Because if patient doesn't follow our instruction, it becomes contributory negligence on part of patient, and it becomes good defense in our favor. So as far as follow-up is concerned, if we have mentioned that please come for follow-up examination and treatment after 3 days, and patient didn't turn up, then it becomes good defense in our favor. One more area as far as references is concerned. If we feel that patient is to be referred to any other specialist for any other ailments, and if you have mentioned, and if patient doesn't follow, then also it becomes good defense. And as far as fetal part is concerned, this is also very good part, because in one of the very famous case which was decided in state of Tamil Nadu, it was premature delivery, and baby was admitted in NICU. During course of NICU and at the time of discharge, because baby was fine within 2-3 days and baby was discharged, but no neonatologist advised to rule out retinopathy due to prematurity, and in due course baby went blind. Case was filed, and compensation of 1.8 crore was awarded to that very baby and family. And out of those, 1.73 crore was to be paid by government of Tamil Nadu, because it happened in government hospital of Tamil Nadu. And rest of the amount was to be paid by neonatologists. In this case, luckily, gynecologists were not made party. So, importance of discharge card in that way also we should consider. Yes, next.
Thank you, sir. Now we have Dr. Kiran Sonwalkar, sir. He is an avid badminton player and does a lot of traveling. He is the secretary of Satara Society. Over to you, sir. Dr. Kiran Sonwalkar. Requesting anyone from Satara to please take this question.
Sagar is there. Sagar, you can take.
Sagar
Anybody
sir
can
is
take.
not there, sir.
Huh? Anybody can take, no issue.
Gauri ma'am, would you like to take this? Can you read it?
Just a moment, madam. So the patient is admitted in labor pains. She was in a good health at the time of the admission. No satisfactory progress. LSCS was advised, and the patient and the relatives were reluctant to give consent for the LSCS. Doctor was constrained due to the non-cooperation from the patient side and relative side, and empathetically warn the attendants, including the patient, either to consent for LSCS, cesarean section, or to take the patient to any other hospital. So after 1 hour, attendants gave the consent for the LSCS, but asking for guarantee regarding mother and baby. So what to do in such situations?
So in this situation, when you first advise cesarean section and they refuse to give consent, then which are the consequences of refusal of consent should be mentioned, and they should get it signed that we were explaining about necessity of cesarean section, but we are not willing to go for cesarean section. After 1 hour, when they became ready to give consent at that time, again, naturally, we have to examine patient and which are the condition of patient or baby. Say, for example, baby is in distress or mother is in distress or any other complication. Then at that point of time, we have to mention everything about a patient's condition and probable outcome due to delayed in that very concern. So if we mention everything and if they sign, then it becomes good defense in our favor.
Suppose, sir, if the patient and relatives will not give the consent and they want to go to the another hospital, in such a situation, we should give a referral letter to them,
Yes, yes,
considering this situation, or we should
yes.
accompany with the
No,
patient.
no, no. We should give reference letter of treatment given at our place. And if we are not held up in any another emergency, then we should escort patient where patient wants to go, and we can make patient to reach there. Because
And
on
in
the if at all anything happens, you have to deal with accordingly. And if you do like this, it shows your consent to take utmost care of any patient. So if at all something goes wrong, when patient leaves your hospital or when patient is admitted to another hospital, you are not at all responsible whatever consequences happened at their place. But we have to prove that when patient left your hospital, uh, vitals were within normal limit or so, or if at all there was any complication, say for example, if it is a case of eclampsia. So at the time of transferring patient, you have given Maxalf, you have given some antihypertensive when patient is having hypertension or so. So you have to mention everything in that paper. And if you have escorted patient, on the way, if at all see through one more feet, you can manage. And when patient is admitted there, then you are out of problem. But in this situation, you will have to explain everything and you have to take sign of patient and patient party that this is the situation and we are leaving hospital against advice of a doctor, and whatever consequences occurs after leaving this hospital, doctor and hospital staff will not be responsible. So if you go like this, but you cannot deny to give document or record of treatment given at our place, even if they are going against our advice.
Thank you, sir. Now this situation is continued. So, Dr. Gauri, would you continue this? Or Dr. Mohini Patwardhan, ma'am, you are there. Would you like to continue with this?
So anybody can take, no issue.
so
I'll con-
LSS,
Yes, sir. Yes, Dr. Gauri, please go ahead.
in this
So it is the
patient,
same case after 1 hour when they gave consent and then cesarean section was performed. Yes, go ahead.
so LSS was performed, and there was a we delivered a asphyxiated baby with a very low Apgar score and had convulsions also, and after some time, and the baby is been intubated to the NICU. The attendants now blaming the doctor, saying a false hope of normal delivery been given or the wrong medications been used. Fetal heart rate was not checked during the labor, and one injection was administered, which we stopped the pain, labor pains for some time, and then created the situation, and that all things landed up the present situation of the baby. So how to protect oneself in such a litigation?
So these are very, very common allegations because after 1 hour when they gave consent and an aspirated baby delivered. So I mentioned prior also. So at the time of this consent after 1 hour when they were ready to give, we have to again explain about a situation at that point of time. And now this is the situation. Even if you are going to go for cesarean section, then also this could be the probable outcome. And we should advise NICU treatment requirement also, because if we have explained that and then we have gone for CN section, it will be easier for us if at all we face this situation, expected maybe and when NICU treatment is required. As far as false hope of normal delivery given, these are very common allegations, and this type of allegation doesn't stand in court of law. Wrong medicine were given, they will have to prove, because whatever medicine given, it will be mentioned in our case paper. And if they can prove that this medicine was not proper or not to be tried in this case, then only we can be held responsible. As far as fetal heart was not checked, we can prove it by our record only, that at date and time, at what time we had gone with fetal heart sound, and how much fetal heart rate was there. So if we have mentioned everything in case paper, then this allegation also doesn't matter. One injection was administered and pain was stopped. This kind of allegation are very common, but it also doesn't stand in court of law, because by our record we can prove that whatever injection or treatment given, it was very much required as per situation in that very point of time. And this created situation, this kind of allegation doesn't stand in court of law, or they will have to prove, because the burden of proof is on shoulder of prosecution to prove that all these allegations they put, and how they can prove that all the allegations were true. So this type of allegation doesn't stand in court of law. Yes, next.
One more
Yes,
question,
yes,
sir, regarding
yes.
this situation. As many of our private setups, we have our attached pediatricians, but we won't have the NSU setup in the same obstetric setup. So in such situations, can it stand in the court of law that the pediatrician is there,
Yes.
and
So
we have
in small nursing home, many of our Foxian friends have habit to keep pediatrician present at the time of delivery, whether it is normal, instrumental, or cesarean section. Because I have the same habit. Till date, how many delivery I have conducted, in each and every delivery, neonatologist was beside me. So as soon as baby is delivered, we hand it over to neonatology. In this particular case, when we went with cesarean section, when consent was given late, and we were suspecting asphyxiated baby, then in this situation, it is very much required that neonatologist should be available in OT. If neonatologist is not available nearby, then only you are pardoned. Otherwise, neonatologist should be there. And when baby delivered asphyxiated, naturally neonatologist will take care to resuscitate baby, and straightway he will take that baby to NICU nearby. If it is not with a small nursing home, doesn't matter. But if neonatologist is there, and if he takes charge of that very asphyxiated baby, then you are out of problem.
Okay. Thank you, sir.
So now we have Dr. Milind Peshavikar, sir, Director of Peshavikar Hospital, Kolhapur. He's been in practice for 35 years and he's the past president of Kolhapur Society. Over to you, Milind, sir. Dr. Milind, sir.
Give me a second. Hello.
Yes.
Yeah. So I have gone on to the video and on the laptop.
Welcome, sir.
So the baby is saved but developed cerebral palsy. Now the attendants filed a case against the doctor. How do you deal such situations? How to counsel such attendants? And how to handle litigation?
Sir, the same case which we discussed prior, in this type of situation, if at all baby is saved but develops cerebral palsy, then prior proper counseling is very much required. When we are dealing with asphyxiated baby, then we have to mention this, that it may occur. And if you have counseled them and it was delayed in giving consent, which may lead to that, could be one more excuse on our part. But very interesting part, as far as cerebral palsy is concerned, whether it is due to intrapartum cause, whether it was due to antepartum cause, or whether it was due to postpartum cause, if we can convince court, then it becomes good defense in our favor, because many a time it could be some antenatal problem which may lead to cerebral palsy in future. And if we can convince, then court also accept our argument, because in few of the cases court has accepted, and our gynecologist friends were saved, because in one of the case which happened in Guwahati, the same situation, and doctor could prove in court of law that it was a problem related to some antenatal issue, and she developed cerebral palsy in future. So that way also we can. One more area as far as scalp blood and pH, if we go like this, then we can prove at the time of delivery there was no problem. So if at all something goes wrong after delivery, then also we can have one good defense. Yes, Milind sir, Milind Bhau.
Now we have Manjula ma'am, sir.
Yes.
Dr. Manjula Peshavikar, Organizing
Yes.
Secretary of AMOX 13, VP of Kolhapur Society. Over to you,
Yes.
Manjula ma'am.
Yeah, a 32-year-old primie whose full term was admitted for labor pain. There was no significant medical history, past medical history. Artificial rupture of membranes was done and liquor was clear. Patient had sudden cardiac arrest while in labor and she became pulseless and BP was not recordable. CPR was started immediately. Amniotic fluid embolism was suspected. The patient was intubated and started positive pressure respiration immediately. The patient showed signs of partial revival. What should be done? Should LSAS be done immediately as FHS was there, or patient should be shifted to ICU or higher center? So who's more important? Probably that's what is the question.
Yes. So I usually mention that law doesn't teach you medicine. How to manage this patient in that very given situation is up to us only. But whatever we do, we should be in a position to justify. And as far as amniotic fluid embolism is concerned, because there are few cases decided in Supreme Court, and in 2 to 3 cases, decision was in favor of doctor. Because in one of the cases which happened with one of our Foxian friend from Ghaziabad, it was a case of amniotic fluid embolism, but it was just after delivery. When patient delivered, baby was delivered, and she went with this problem. She was resuscitated well. She was transferred to nearby ICU unit, and during course of treatment, patient expired and case was filed. So in that very case, lower court and medical council of UP held doctor responsible. So appeal was filed in High Court. High Court also didn't give relief, and ultimately case was filed in Supreme Court. And at the time of fighting that case in Supreme Court, medical legal counselor entered in the picture, and the case was discussed in Supreme Court, and we came with standard textbook Williams, all the references related to amniotic fluid embolism. What is amniotic fluid embolism? Whether it is a dead condition? Yes. Is it known complication? Of course, known complication, but rare complication. And how patient can be managed in this type of situation. So whatever written in that very textbook of William was done by that doctor, and doctor was saved in Supreme Court. So how we represent in this type of situation in court is very much important, and here comes importance of our documentation. So if at all it is a case of amniotic fluid embolism, and how we try to resuscitate a patient, and so how we went with resuscitation, and how we refer that very patient in nearby ICU with escort, with positive pressure oxygen cylinder on, IV line on, all emergency medicine, etc. Then it shows your consent to save life of patient. Because in one of the case of Kusum Batra, in that very case, Supreme Court has mentioned that doctor has to take decision in many situation, and when he knows that this is almost near miss case or gone case, then also he has to try, but he should not be in a tension that litigation could be there. So in this type of situation, doctor should, court should be liberal to decide as per given situation and what doctor has done to save life of patient. And in both these cases, it was case of amniotic fluid embolism. Our doctors were not held liable and they were freed from the charges. So it is very important how we present our case. Yes, Milind Bhau, any comments?
So again, the question is whether to save the baby or the patient.
Naturally, to save mother.
Okay, fine. The second
Because
question
she
now,
will conceive again.
the second question to this is, there are many cases where people are now the court is asking whether you have an attached ICU in your hospital. How much mandatory is it to have an ICU?
No. So it was observation and suggestion, but it is not like that, because if it is there, then small nursing home in India will be closed. So it is not there. But you should have access nearby if at all situations happens, and after resuscitating patient, you have to quickly refer that very patient or transfer that very patient with escort in nearby ICU. And if you can prove that, then it is fine.
Thank you, sir.
Now we have Dr. Manisha Ladad.
Hello,
She
ma'am.
was driving and she had played cricket in her college days. So over to you, ma'am.
Yes. Good evening, ma'am and sir. My question is, if patient immediately dies or expires, how we should handle this situation? So we are doing, for example, I'm doing a cesarean section and patient land up in PPH and suddenly, in spite of managing such cases, he dies on table. What is the way we have to handle such situation?
Yes. So there are two situations. If patient is expired and in spite of all your measures for resuscitation, you couldn't revive that very patient, then how to declare that very bad news? One part, whether postmortem examination is to be subjected, second part, and police is to be informed, third part. So as far as declaring bad news, so if you have rush team in your society, naturally in this situation you should call a member of rush team, so they can be at your rescue at the time of declaring bad news. One more part, even if you know that it was case of postpartum hemorrhage, severe postpartum hemorrhage, and if it is young patient, you can advise them to go for postmortem examination. Because if there is a cause, I mean postmortem examiner will give cause of death that it was cardiorespiratory arrest due to hypovolemic shock due to PPH, then it will be established that it was case of PPH. And how you try to handle that very PPH case as per standard medical norm, then it could be good defense in your favor. And the third part, police is to be informed. So once you inform police, then custody of that very body is with police, and police will subject postmortem examination. Many a time in this type of situation, relatives are not willing to go for postmortem examination. But once we inform police, onus on shoulder of police to take body for postmortem examination.
Thank you, sir.
Ma'am, please continue. This is
Okay, so sometime what happen, patient becomes serious when we are managing the case in our private hospital and we are shifting that patient in ambulance. On the way, if unfortunately patient dies, then relatives becomes very aggressive and they will bring that body back to our clinic. So how we should manage such situation?
In so many of my lecture, I have mentioned that when you are referring patient to higher center, one more very important question comes. Can we see patient who is hemodynamically unstable? So we have to resuscitate or we have to stabilize patient first, and then we have to refer that patient, and we have to escort that patient with all emergency medicine, oxygen, etc., IV line on, etc. So it is double-edged sword to refer patient to higher center. If we refer late, then question will be then why you didn't refer patient well in time. If we refer straight away without stabilizing the patient, then again one more question will be there, that why you didn't refer patient after stabilization. So whatever decision you take as far as the reference of patient to higher center is concerned, you should be in a position to justify your action in court of law. So usually hemodynamically unstable patient should not be referred are the inference in so many of the cases on part of court also. So you have to stabilize, you can involve your other professional colleague at your place to manage the situation. And if patient is stabilized little, then with escort you can refer patient to higher center.
Yes, sir. Thank you, sir.
Now we have Dr. Monica Kulloli. She is the past president of Meerut Society. Ma'am, are you there? Or I would request Dr. Manisha, please take this. Dr. Manisha, ma'am?
Yes, I will take.
Yeah,
So
please.
this is the scenario. Second gravida primipara having one living issue. She is averagely built and having previous LSS and had a planned cesarean section. Intraoperatively, it was uneventful. There was no significant medical history. Patient was planned for discharge on 4th postoperative day. And on 3rd postoperative day, patient was we have taken her dressing and suddenly patient gets collapsed. She becomes cyanosed. CPR was started but should not be revived back. So the cause of death in this patient was pulmonary embolism. So sir, can you tell us how to deal with this situation?
So this type of
Attendants have started creating nuisance. So what should we do in this situation?
Yes, this type of situation really happened in city of Ahmedabad only. It was a case of cesarean section. Patient was discharged after 4 days, and on 6th or 7th day, patient was advised to come for dressing. And patient was on table, and during dressing, for any reason, there was sudden collapse. Gynecologists tried to revive patient, but they couldn't, and these were declared to relative, and relative were very agitative, and they were doing nuisance. So in Ahmedabad there is rush team. Ahmedabad is a big city, so area wise there is rush team. So in that very area, doctor had a phone call to one or two members of rush team. He called me also in that very situation, and you won't believe within 1 hour or so, almost 150 gynecologists were there at their very hospital. So I advised post-mortem examination. I was there, and relative refused. So we do not want to go for post-mortem examination because we were explaining them that everything was fine. And suddenly whatever happened, we do not know why this happened. So to know exact cause of death, we should inform police and we should go for postmortem examination. So we informed police came. Relatives were very reluctant that we do not want to go for postmortem examination. So it was middle of night. Police had a phone call to magistrate, district magistrate, and he had been there, and statement from patient's party, that is relative, were taken that we do not want to go for postmortem examination anyway, and we have no complaint against this hospital or doctor also. And in this case, that case was closed at that level only. But in this situation, other than this, whenever there is a pulmonary embolism suspected, then naturally we will try to resuscitate patient. And in spite of all this, if it is not saved, then it always insists for postmortem examination. Because to know exact cause of death, it is very much required. Because when patient is fine, patient has come on foot for dressing only, and on table, if sudden collapse happens, then it is very difficult for us also to explain to the patient, I mean patient party. So it is always better to subject body for postmortem examination.
Thank you, sir.
Thank you, sir. Now we have Dr. Mohini Deshpande. She's a Bharatnatyam dancer.
Very good.
So, and she loves traveling. She's a laparoscopic surgeon and cosmetic surgeon. So over to you, Dr. Mohini ma'am.
Good evening, everyone. My question would be to sir, against whom a medical legal complaint can be lodged, and where can this complaint be lodged?
If we answer first question in one line, against any healthcare service provider, complaint can be lodged. Whether he is doctor, whether he is staff, say for example, if it is dental surgeon, pharmacist, radiologist, sonologist, against anybody, one can complain about the medical legal problem. Where can complaint be lodged? So for that, how patient party is interested, that depends upon that. If they are interested for compensation, then they will prefer civil complaint or complaint under CPA. If they are interested to lodge complaint criminally, then they will lodge complaint in police station or in criminal court as far as criminal allegations are concerned. A departmental inquiry, say for example, it is in government hospital, then they can write to government to have a departmental inquiry about this case. They can go with some commission also, Human Rights Commission or any other commission in that way complaint. In council, medical council or NMC, they can lodge complaint. Even in few of the cases we have faced that they have complained in medical council asking to suspend registration of doctor. I have defended so many doctors in this type of situation. So patient have so many choices, I would say, as far as complaint is concerned. They may lodge complaint at any place. They may go with simultaneous complaint also. Say for example, they may lodge complaint for compensation in consumer fora, and they will lodge complaint in police station also. They will lodge complaint in medical council also. So they can go with multiple complaint at a time also.
Okay, sir. My question for you is,
Yes.
sir, if there is a gynecologist-owned hospital who has employed maybe 2 or 3 junior gynecologists who have a proper MS or DNP degree with them, and they are working independently as well in that hospital. However, does the vicarious responsibility still stand with the gynecologist who
Always
is the
yes,
owner of that hospital?
whatever happens under your roof, you are jointly or severally responsible. So if patient made you party vicariously liable, then you will have to prove that this case was solely with Dr. So and so. I have never examined that very patient, and all the care was taken by that very doctor only. And you can ask for to delete you from the party on first hearing only. And if court is convinced that you are not involved in treatment, then you could be out of that very case as a party.
Okay, thank you.
Thank you, sir. Sir, Dr. Nirupama has joined. Dr. Nirupama, ma'am, she had to go out for an emergency, so she has joined. Now it is an open session for all panelists. Anybody wants to ask anything?
Yes, even Nirupama madam has, if any question, then welcome. Or any panelist can take. But before that, again, I would appeal for my candidature for President Foxy this year. Please consider, please endorse and vote for me. From 1st August to 10 August will be election. And before that, in this month only, there is a time for nomination from all the society as far as this post is concerned. And just mentioned by Dr. Asha Jain also, she is going for chairperson Food, Drugs and Medico-Surgical Equipment Committee Foxy. So I appeal on behalf of her also to nominate and to support her candidature. And as far as her election is concerned, it would be from 16th August to 25th of August. And in that, society votes. So president and secretary have to vote. So this is humble appeal for her also. Yes, any question from any delegates? Most welcome.
I have a question, sir.
Yes.
So, as we know, at times we deliver or do cesarean for a patient, and then before discharge, we have to leave for either work or leisure. And if at all, till discharge, till day 3, patient is with us, patient is all fine, we have done all, kept all record. So, if after we leave, the patient lands up in some complication, how much liable are we? If we have already given standing instructions that if anything happens, you have to refer the patient here.
Yes, in this situation, if you have delegated duty in your absence to locum, then locum should be equally competent. Say, for example, you are MD or MS Gynec, then locum should be also MD or MS. It is required and expected on part of law. And you have to explain to the patient and patient party that tomorrow onwards I am not available, but Dr. So and so will take care. If they are ready, it means they are mentally prepared to take care by that doctor if at all any complications happens. If they are not willing, then we can offer that you can be shifted to another hospital also of your choice. They may decide to go for nearby medical college hospital or in another private setup, they can. So you have to explain that you are not going to be available from next day in routine manner, in routine, not for any case which you have already operated, but in routine manner. Say, for example, you are going to go for vacation for 1 week or 10 days or so. So in this situation also, if it is possible, then you can give in newspaper that I will not be available from this date to that date, and Dr. So and so will be there. But at least you can put in your visiting area, that is reception area, that I am not available from this date to this date, and Dr. So and so will be available in that very period. If patient comes in your absence and that doctor is available and patient is ready to be examined, ready to be treated by that doctor, then you are out of problem because patient has accepted that she is ready to be treated by that locum doctor also. But these are part of proper counseling only. If you have counsel patient, patient will think that they are not left alone. You have managed for her also in your absence.
Okay. Thank you, sir.
Yes, any other delegate? Or should we conclude?
There don't
Yes,
seem to be any other questions, sir. So I
Yes,
think
we
we
can
can conclude the session. So, Namaskar. Thank you very much for attending this webinar. I thank MC Patel, sir, for actually putting this whole program together with so much of an effort. I thank Dr. Monica Umbardan for helping out, being the coordinator, Dr. Rekha. I also thank all my panelists, especially those who are sitting right up to the end, Dr. Mohini Deshpande, Dr. Gauri Shinde, Dr. Manjula Peshavikar, Dr. Milind Peshavikar, and all the other panelists who have been here till the end. I thank all of you. I also thank all the viewers. I thank Corona Remedies and Tirth Shah for being our academic partners. Thank you so much. See you again in
All the best, sir.
Happy Learning
All the best to
193.
Dr. MC Patel, sir.
Thank you, sir.
Please
Thank you, sir.
nominate
Thank you,
me
ma'am.
for food
And
drug
thank you, sir.
committee from your societies and sir for President Foxy. Thank you so much.
Thank you.
Thank you, ma'am, and thank you, sir. So, with your permission, I am ending this session.
Oh yes, we can conclude.
Okay.